mono products. The Suboxone.
Oh.
Suboxone is buprenorphine and naloxone.
Okay. Which I don't understand why they would have like naloxone.
I will tell you
Oh.
if you want.
Yeah, sure.
A lot of people, so the reason why Suboxone is the gold standard, there's two things that it does that are really helpful. It binds to the receptor really tightly, and it doesn't stimulate that receptor that much, which is why when you're on Suboxone, it's harder to get that euphoria that the drugs give you.
Withdrawal, right?
Yeah, so it also makes it kind of tricky to start, because it binds so tightly to that receptor, if you start it too soon, it can kick things off and it can precipitate withdrawal. So it's a bit trickier to start. So it binds really tightly to that receptor. It doesn't stimulate it that much, but because it binds so tightly to that receptor, it's actually really good at preventing people from having overdoses. So I've had people who they might do like half gram like hits in community, and they got a huge tolerance. They're using a ball a day, and then they come in and we get them on Suboxone, and they're like, I'm not feeling it, but they want that euphoria. So it's kind of tricky for that reason. But the Narcan, a lot of people think the Narcan is what makes it prevents overdose, and it's not. What's that?
Where the weights bring up.
Yeah, that's what Narcan does. It kind of like it kicks off those opioids from the receptor. But the naloxone in the Suboxone is only there to prevent diversion, because it's only bioavailable if it's injected. Suboxone goes under the tongue, it dissolves under the tongue, sublingual, right? And when it's ingested sublingually, the naloxone doesn't do fuck all. But when it's injected, the naloxone will work. So really, the naloxone is just used to prevent Suboxone from getting diverted. Now, when we give a Sublocade injection, which is a 1 month injection, which is great in many ways, especially if you're looking to move away from the life, we give into the belly. It creates a little lump in the fat. What's that? Like it has like a bead or a little marble. It's slowly released into the bloodstream, but because we don't want to put Narcan in there because it's bioavailable when it's injected, it's just a mono product, meaning it's just buprenorphine. So basically, when people come to the hospital, like I said, we're competing with the unregulated drug supply. So we want to make sure they're comfortable. We don't want people to be sick, and that can be a challenge because everyone's got their own unique tolerance. You might be using a point a day, you might be using a half ball, you might be using a ball a day. So we got to figure out like how much you're using, and then like supplement you with stuff that we have, which is not nearly as good as the stuff that's out there, potency-wise.
When you're considering what they're using, are you considering how they're using it, like how, like smoking it or injecting it, and then finding alternatives that are the same as if they smoke it or inject it or whatever?
Yeah, that's a good question. I mean, the first thing we're doing is we're like, through our assessments, we're figuring, okay, how much do you use? Okay. And we know that there is a wide variation in how much down is in each point, right? So you can take a point, you can buy a point and there might be like 0.5% fentanyl.
Mm-hmm.
And then you might get a point that's like 25% fentanyl. And then you might get a point and it's like 80% fentanyl, and you're like dropping and dying immediately. But because it's unregulated, there's no consistency. So even if you say, hey, I'm taking 5 points a day, and someone else says they're taking 5 points a day, and the other person says they're taking 5 points a day, they're still probably taking different amounts of fentanyl. Mm-hmm. So it's really a bit of a guess.
I mean,
how much they're taking. I'll just give me one sec. But yeah, I mean, 9 out of 10 people are smoking, they're down. It's pretty quick, just like injection. It's less risky than injection, but it's still super dangerous. But when they come into hospital, we don't have any meds that people can smoke. We have a lot of oral meds that take a bit of time to absorb, and then they don't give you that kind of rush or that euphoria. We have injectable meds that we can give. but then that causes nursing a bit of stress because that needs a bit more monitoring. So like one of the things that we're having to like evolve is that the tolerances have gone like sky high, right? Back when I was in nursing school, like 4 milligrams of hydromorph was a lot. And if you're a little old lady who's never done any hydromorph or any down or whatever, 4 milligrams of hydromorph can knock you out, and you need Narcan. That will kick out your respiratory system. Yeah, some people are just super sensitive, but we call it opiate naive. You know, if you're smoking a ball of down a day and you come in, 4 milligrams is fuck all. So you need a lot more. And you know, in healthcare, we were told, listen, don't give start low, go slow. Don't mix down with, or don't mix opioids with benzos. Don't mix with alcohol because they can both knock out your respiratory system. And now, because of this like exploding unregulated scene, now we're having to contend with the fact that tolerances are crazy high. Like back in the day, 4 milligrams was a huge dose, and now we're routinely seeing like 32, 64 milligrams an hour. We had one girl who was pregnant. She was on like 130 methadone, and then we were giving her 128 milligrams of hydromorph every hour, and she wasn't even sedated, which is like mind-blowing for the average nurse who's like, that is never, like nothing about 128 milligrams an hour seems safe. But yet that's what we're having to do to keep up and keep people comfortable in order to make sure they stay in hospital and get the care that they need.
And the
So
combination of the benzos with the opioids.
then there's the combination. So that's the thing. It's like we were always taught like, hey, don't mix benzos and down and hydromorph or opioids. But that's exactly what the unregulated system is doing. So now we're having to catch up. And so we'll be giving people a bunch of hydromorph, and then all of a sudden there's, you know, the nurses calling me like, hey, they're agitated, they're restless, they're like, they just had a seizure. So now we're having to adapt and evolve, and instead of not mixing benzos with opioids, now we're having to give, like, we're doing benzo tapers in hospital because we have to
Valium?
what's that?
Valium?
Yeah, that's what we use generally. We have to kind of like evolve with the problem, and the crisis is evolving so quickly. We have to evolve quickly too, but healthcare takes a bit of time to like. It doesn't adapt as quickly as I'd like, right?
Yeah.
And you know, it takes a lot of time, and a lot of things like healthcare is generally evidence based. We like evidence to support our decision making. And there's not a lot of evidence in a lot of the things that we do. We are in evidence generating times. So a lot of our physicians are doing things like doing benzo tapers with their opioid replacement orders without evidence. Kind of risky, but it's also what we have to do to kind of keep up with the problem. And we know that the people who are kind of like running the unregulated system, they're going to be shit about evidence. Right, so it's just like, how do we make the most amount of money possible? And so it's kind of it's complicated because we're trying to kind of keep up and catch up with the problem as it's expanding, as it's evolving, as it's kind of like morphing. We're trying to keep up with the contaminants and be like, okay, now like, what do we do when someone's like loaded up on xylazine or all these new fentanyl analogs that we just don't have much data about? And so yeah, like figuring out what people's tolerance is a challenge when everyone's tolerance is different. Giving them the medications in a way that is going to make them comfortable, and like when people are used to rapid onset fentanyl, hits you like a freight train, feels great, burns off quickly, but we're giving pills that take 20 minutes to kick in and last a bit longer, we just can't compete with the illicit stuff. You know, our team and a lot of people in hospital recognize that like some people are going to continue to use while they're in hospital. I mean, there was for the longest time an expectation when you were in hospital, you are not to use down. You are not to use drugs, illicit drugs.
But
And
people are going to whether you want them to or not.
Exactly. So they're going to
That's why you should have opiates in the hospital.
Exactly, we're getting one. It's coming.
Nice.
So that is part of the culture that we're trying to change. And I can assure you that the culture is changing. That's a big part of my job, which is like changing the culture in the hospital. Culture is changing. Things are improving, but it's happening slowly. And I wish it was happening faster because we're in a crisis and people are dying every day. But good things are happening. We're getting more nurses that are allies, more nurses that reach out to me, be like, hey, what do I need to do to be a better nurse with these folks? Because it's a struggle.
You should have an alliance.
Well, we should do.
Start.
We should.
Yeah.
You know, I know Victoria, they work with the Umbrella Society down there, and they've got peers coming into hospital. I'd love to see peers coming into hospital. Hospital historically hasn't been a safe place for people who use substances, and that includes peers. I consider myself a peer because I was on the streets. I was into drugs for 23 years. What?
What's unsafe? What makes it unsafe for the peers?
Well, it's just
There's power, man. There's,
inhospitable environment in a hospital.
Yeah, I mean, what makes it unsafe is that like
The stereotypes.
there's stigma, there's stereotypes, there's assumption. Like when you come into the hospital, you're in a completely different land. You are in, and you are in an institution with a lot of moving pieces, a completely different language, people with a lot of power and a lot of intelligence in certain areas. People who have been socialized in very patriarchal, hierarchical kind of like systems.
Anti-drug waste.
Yeah. We like to maintain control. We like to, there's this power differential, which is keeps things working in some ways, but is also not helpful
Not adaptable.
when people come in and they're disempowered, they're marginalized, they're disenfranchised. You know, you're in our house, we're given the orders, they're on our timelines, our schedules, our lingo, our machines, our tests. You got to be around for it's almost like our team and people in mental health substance use are very patient-centered, trauma-informed, culturally sensitive. We want to meet people where they're at, but then when the acute care system isn't designed to kind of meet people where they're at, it's more about like how do we get these people into our system and help them with their medical stuff.
More integrated.
Yeah, so it's like a super.
Assimilated.
It's a super big challenge. Now, I mean, a lot of good things are happening. Like I say, culture is slowly changing. I mean, obviously the problem is exploding. More and more people are coming to the hospital to use substances. Whether it's directly related to those substances or indirectly related to those substances, right? Directly being like, okay, you've overdosed, you've got a compartment syndrome.
What's that?
Compartment syndrome. So in our muscles, they're kind of encapsulated in these things called fascia. They're like bundles. And when you cut off the blood supply to a muscle, it starts to inflame. And when it inflames, it can't expand, so it kind of compresses the vein or the artery, and it cuts off blood supply. So we see this a lot with the benzos and the down. These people will like go down and they'll cut off the blood supply to our lip. When we're sleeping, we're constantly flipping in our sleep to kind of keep the blood supply going to different areas of our body. But when we're out and we're compressing, say we're in a weird position because we're all benzoed out, and we're compressing, say, our arm or our leg, that's cutting the blood.
Just way down like this.
Yeah, that's causing decreased perfusion, decreased blood supply to the muscle.
Killing your limb.
Yeah, the muscle is starting to die, and then it's getting inflamed, and that inflammation further cuts off the blood supply. So then what happens is people's tissues die, and they come in, and they got massive wounds, and eventually the doc's like, it's got to come off. It dies, it goes gangrene. So that's why you see more people with legs, arms, wounds, and then you got xylazine, which is creating kind of like wound issues. So
there's an increased number of amputations then?
Yes.
Fingers, wrists,
I would
hands?
say
Feet mostly.
I would say lower limbs.
Yeah.
Predominantly.
Okay.
Like anything more distal or farther away from the heart is going to be at higher risk.
Can you make any comment about endocarditis? Is it up or down or
I
is
don't
not?
know exactly,
Okay,
but
just thought I'd ask.
yeah, I mean, what I will say is like the switch from
Injection.
injection to inhalation, whilst it hasn't really done much for overdose
No.
deaths
I agree.
because it's still like super
Yeah,
quick,
fix your brain, yeah.
you know, the risks of injection are still quite a bit higher than the risks of inhalation because with the,
Your blood back in
with-
yourself.
so what happens, endocarditis is, yeah, so you get bacteria in the bloodstream,
Forgotten valve.
and it gets into the heart, and there's these different chambers in the heart, and there's these little flaps that go between the chambers, and those flaps are really important. They keep blood going one way. It's like traffic light that keeps kind of traffic flowing in one direction, and we don't want traffic backing up. And those flaps open one way, and then they close, and they keep the blood from going back up. So, and they're very delicate. They're like tissue paper.
If it breaks off and goes through that cardiovascular system, it goes through your
Well,
brain, right?
yeah, well, it could do. So what happens with endocarditis is if you get bacteria into your bloodstream, you can get sepsis, you can get infection, but you can also get these like vegetations in your heart. You can get these like little bacterial growths on your valves.
Forgotten valve.
What's that?
Forgotten valves.
Forgotten valves?
That's what they call it.
Okay.
Forgotten valve,
Yeah.
It breaks off, it goes all the way through the cardiovascular system.
It could do. I mean, the bacteria can destroy that tissue. It creates these vegetations, and it can keep the blood. It can allow the blood to kind of back up where it shouldn't. And yeah, it can also like embolize. It can break off, and they can kind of seed infections in different parts of the body. So endocarditis, cellulitis, like infections of the tissue, infectious diseases, like all those things that were like much more likely with injection drug use. You know, if more people are smoking, less people are going to be getting endocarditis, getting sepsis from, or cellulitis, getting, you know, HIV or Hep C from sharing
MRSA
rigs.
is susceptible to that too, right?
MRSA, yeah. I mean, MRSA is ubiquitous. I'm sure like everyone in this room has MRSA. Like most, I think it's like, it's pretty common at this point. It's just everywhere. Anyway, so, you know, I don't know exact numbers, but
Where are you?
I think when it comes to like endocarditis, yes, we still see it.
Right.
Yes, it's still devastating, especially if you're 20 or 30 and you get endocarditis.
Can it happen with teeth?
Yep,
Okay.
Okay.
yep. Like, I mean,
Yeah. Right.
it can definitely happen with like, you know, chronic tooth and gum decay.
Yeah.
You know, anything where there's like chronic infection, you're gonna run the risk of having endocarditis. But with injection drug use, you're bypassing all of those kind of barriers and protective kind of barriers, and you're just going straight to the blood.
Okay.
So it's much higher risk.
Put your old blood back in.
Yeah. I guess, you know, talking about some of the wins, like our team does a lot of good work. We see about 30 people a day on average, and we connect a lot of people to, like, we keep a lot of people comfortable. We manage a lot of people's withdrawal. We make sure that they're getting their needs met so they can stay in hospital and get
Who
the
do we
care
ask
that they
for?
need. What's that? I'll get to that in a second.
He's chomping at the bit.
I know. That's the crescendo.
That's where the
of my-
rubber
my
meets the
speech.
road.
You know, we're helping a lot of people transition to supportive housing, or some, like a lot of folks, if they want to go to treatment, we'll help with that. That's a challenge. You know, we're connecting with our community partners, our outreach teams, other social services, case managers, making sure that when they get discharged, like they've got the meds that they need in order to be safe. We are working on an OPS is coming to NRGH. It was supposed to be up and running in February. I don't think it's not going to happen. That's not going to happen, but it is coming at some point this year, and that's been a good thing. And that's been in reaction, I think, to the fact that we've got this like kind of workplace workers, what do they call it, WCB kind of order. So one of the problems that we have, and this is a huge problem, is that a lot of people continue to like use in the hospital, in their rooms, and they smoke in their rooms.
Where they become isolated and they're more at risk of dying.
Yeah, so this is where we're kind of like stuck in between these things, right? Because like we want to keep people comfortable, but we struggle with it because we're busy. Like the nurses are busy. We have all sorts of conflicting priorities.
Right.
People end up using their own stuff. They end up smoking in the bathroom, and then a nurse walks in and they get exposed. So we've had a massive increase in like exposures on staff, and that's problematic because then there's less staff working in the hospital,
Can
and then
you-
people's care goes down.
As someone who's been hotboxed many times
Yeah.
and never had a problem,
Yeah.
can you explain what you mean by exposure? Is it because they psychologically know they've been exposed, or is
Yeah.
there really some symptom? Because I know I know WorkSafe because I've been hassled by them too.
Yeah.
I mean, just saying, and I don't want to play it down. It's just like for us to know, like,
Yeah.
how is it that they know? They just smell it and then they go, "That's it, I'm exposed."
Well, anecdotally, a lot of them walk into a room, they smell it, they feel restless, anxious,
Right.
tachypneic, they start breathing really fast, some of them start hyperventilating. OHS, Occupational Health and Safety, would be better to speak to actual numbers, but what we know is that people, like nurses, aren't going down and requiring Narcan. Nurses aren't dying from a toxic drug exposure. We know that. Just like staff at OPSs aren't going down needing Narcan and dying from a toxic drug exposure, but they're still, whether it's physical or psychosomatic or psychological, they're still having experiences
Over a long
with
period
these
of time.
substances.
I get it.
They're still presenting themselves to emergency rooms. They're still going off on leave.
Still rules, right?
They're still scared. It's just like you get
They're just getting scared.
yeah. So you're right. You're right. I mean, a lot of them are having stress responses. Whether or not that's because of the drug that got into their bloodstream, we don't know because we're not doing blood tests on these guys. But they're still going off on leave. They're still, getting disability and all this kind of stuff. So it's expensive. And to be fair, like a nurse comes to work, you want to care for people, do your best. You don't want to be exposed to shit that you don't choose to get exposed to, right? So that's fair. The problem is like we don't have safe places for these guys to go and use.
And why is the urgency not there then? Because I'll tell you what it looks like. A
Well,
fucking tent
I'm
is
not
what
going
it
to
looks
speak
like.
for like.
It's not
I'm not going to make assumptions.
Yeah.
I mean, I agree that a lot of these issues need to be treated with a sense of urgency that they haven't been. I mean, we are in a crisis. We've been in a crisis for years now. We saw with the recent crisis called COVID-19, shit got done quickly, and mountains got moved. Bureaucratic mountains got moved stat to change the infrastructure and the human resources that we needed to make things safe. And we're not seeing that same level of urgency in
Yeah, more
healthcare.
people are dying of the toxic drug
Yes.
crisis than they ever have with COVID.
Exactly. So I get that discrepancy, and I can't speak to
Way more
why,
than that.
and I make the assumption that boils back to stigma and just like, hey, this is not a priority. We got all these conflicting priorities, and this is just not one of them. The good thing about this workplace thing, which is coming from a lot of these exposures that are happening, all these nurses going off, is that it's kind of like kicking people in the butt. Like you gotta make things safe for your staff, and until we have a place where people can use substances safely, we're gonna have these exposures. So I'd like to think, hey, it's we're coming up with an OPS because of advocacy for patients, but I think it's probably more coming from advocacy for nursing safety. We've been what's that?
The whole medical portion and like the drugs, like being exposed to things that they're uncomfortable
No.
with. Isn't that kind of what they do?
No.
Like on daily?
Nope. No.
That doesn't make
We-
sense. They're comfortable by being exposed to a virus, but not to a drug.
I don't think
They're not
so.
comfortable
I don't
with
think
that.
so. So like, I guess to clarify this, like nurses handle a lot of drugs every day. Nurses are able to control their environments to decrease that risk. They have PPE, they have processes, they have things so that if there's a dangerous drug, say chemotherapy, there is a process that the nurses can give that drug without taking on the risk. The way I see it is that we want to decrease the harms to our clientele, to people who use substances, as much as possible, but we don't want to take that risk and put it on the shoulders of nurses. Because how are they supposed to do their job if their level of risk is going up and up and up? So what I want to see is like the risk coming down to patients, but I don't want to see that risk kind of going onto the shoulders of nurses. So trying to get both those down, recognizing there's always going to be this gulf in between. So nurses are exposed to risk through the drugs that they give, but we use tools in order to make sure that the nurses aren't getting sick, right? COVID happened, right? There were new processes, there was masks, there's PPE, there was all sorts of things that happened.
COVID spread in the hospitals and doctor offices?
No. Most of COVID, no. Most of COVID, I mean, COVID is a worldwide
I don't
pandemic.
know what worldwide though, I mean, like here in my homes, like there was like a.
Initially, you mean?
She's talking about the long-term care facilities, which was clearly obvious, but you know what I'm saying. I don't think we should get too
Yeah, I
diverted
mean, I'm not
into
gonna speak on
COVID.
that stuff, but I mean, COVID is everywhere now. Like, I mean,
No, it
whenever you get a group of people in a closed space, regardless of what tools you have, there's gonna be exposure risks, right? I mean, nurses do come to work and are exposed to risks all the time. I mean, the big risk of nursing is like musculoskeletal injuries and like falls and slips and ruining your back from lifting someone, right? So it is a risky job. Nurses get assaulted more than police officers. Like the risk
Oh,
of
yeah.
the risk of getting assaulted is much higher if you're a nurse than most other professions. So it is a risky job, but like, you know, we don't want to be like, oh yeah, we'll just keep taking more and more risks, right? So from my perspective, personally speaking, like we want to decrease the risk to patients as much as possible. We don't want to put that on the shoulders of nurses because they're going to be like, fuck this job, I'm out of here, and that's going to make our crisis worse because we have more people retiring, less people coming into the profession, and we don't want to be scaring people away by saying, you know what, like part of your job is getting exposed to meth.
More candy stripers.
Part of your job is to get exposed to this like toxic drug supply. Like, no, it's not. So like we're trying to adapt and again, like it's going to take infrastructure and human resource investments to make that as safe as possible. So we have to respect that, like, you know, nurses have a tough job. It's dangerous. It's
Okay.
naturally dangerous. We don't want to increase the risks to nurses, but we also have to find unique and nuanced ways to decrease the risk and harms to people who use substances.
Which is why we need more peer support work
Yeah.
with the nurses.
Yeah.
And
they're
can
doing
we
that-
can we go into some of the very specific things, like, I don't know if you're ready for that, but.
Sure.
Yeah. So your question was,
I had a bunch.
when you're heading to the hospital.
contact?
Well, and the other one is like if you're,
The main one.
Yeah.
if you're
Which
bringing
team would you
someone
ask for
else.
first?
So when
How do
you come,
get help?
Because when you get there, you're shook, right?
How do you get
And
help as a
you're
person?
gonna be judged.
yeah, okay, so.
Because you're a drug addict.
Okay, so a couple things are happening. So we have there's a new like vending machine outside of Merge where you can get harm reduction supplies. Okay,
Yeah.
attached to that vending machine is a support worker who is attached to our team. His name's Ryan. He's just started
Your team is called.
Addictions Medicine.
That's what we asked for.
And when's Ryan there?
That's.
At same time as everyone, Monday, Friday, 8 till 4. Until I know. Again, it's not ideal, but it is what it is for now. Part of his job is going to be supporting people coming into the department, liaising with staff, making sure people get medication.
So he can talk to these nurses and calm them down.
Yes.
And let them be less.
Yeah, that's part of his job,
That's the
and
main-
that's
that's
the
the
vision.
Yeah.
Another thing I've advocated for, and they're gonna give me this, is an emergency-based substance use nurse who is gonna identify people as soon as they come in, who needs meds, let's get those meds to them now. Because what happens now is you come to Emerge, you wait around for an hour to get triage.
Yeah, what
Then-
happens when there's no addictions medicine person on staff, right?
What?
At
There's
night,
only
she's
Monday to
talking about
Friday
nights.
between certain hours.
Yeah.
Like what happens? Because most of the time they're gonna probably go in at night.
So, I mean, this is a good question. And again, we've come a long way since there was no AMCS 10 years ago.
Mm-hmm.
But obviously, like, ideally, in a perfect world, we'd have
The
24/7.
general
a day.
public knowledge out there still is, I'm not going to the hospital because I'm not gonna get the help I need when I
Yeah.
go there.
Working towards
And I'm
it.
gonna have to go into withdrawal and.
Yeah.
So
A
it's
lot of people do feel that way. You know, we are working within a lot of constraints. One being like, we need people to do these jobs, and on every unit, they're short a whole number of nurses. I mean, when I started nursing, it was like 4 patients per nurse. Now it's like 8
I'm
sometimes.
constantly
You
advocating
had
now
no
So
for
that-
because
them
you
people
knew
to go in.
already
I was-
what the street life is like,
Yeah,
right?
yeah.
I'm constantly advocating now whenever somebody says they won't go in because of drugs or whatever, I'd say, no, go in, ask for addictions medicine.
Yeah.
Every time you go in, they will meet you where you're at in your tolerance levels.
Absolutely.
And they will get you
Yeah.
home immediately,
Yeah.
but then I'm getting met with, well, there's no one there when I go in, there was no one there
There
when
might
I went
be.
in.
Yeah.
And
There might
different
be.
people will come back to
I
me
had
and
them
say
sit with
that.
me, I had the ambulance attendant sit with me through
Yeah.
just about the whole thing, they left, and they kicked me out of the hospital right
Yeah.
after. They didn't give me they took all my blood and everything else, but they never let me know what was caused or anything, what I could do, what was there, nothing, they gave me no information whatsoever other than get out of the hospital.
Okay.
You know,
Tell them who
just
told
go
you to get
there.
out of the hospital.
Yeah. That's what they said, get out
When
of
you
the
get
hospital.
released, it wasn't a nurse or a doctor,
It
right?
was a security.
Yeah.
Yeah, it's a
Yeah.
goon squad.
They couldn't even-
something I
they couldn't
hear-
even be
I-
polite
I-
enough.
My son beat up the
I hear that a lot.
They couldn't even be polite enough to have a doctor or a nurse come and ask me that, okay, we're done with you, you can go now. We're
Your
gonna
team-
hold
your
you
team
later
go.
or anything, right?
Yep.
And I mean, they got my emails, they got my phone number, they got everything, but did they call me? No. So why go to the hospital,
I hear you. I agree with you.
right? There's no sense for me.
I
to
mean,
go.
we've got this reality, which is like, it's a massive building, you got a lot of moving pieces, you got a lot of people who are like really intelligent and really good-hearted, want to do better, don't have the tools they need to do their job as well as they could for this population. And just like any big institution, whether it's like healthcare or government or police or whatever, education, you're gonna get a lot of different people. A lot of them are good, some of them are just not that good. Some of them come with their own stigmas, their own lived experience, their own biases, their
Some
own
not kids of
judgments.
their own, some
And,
don't,
and like,
right?
that, I mean, all of that is outside of my control. So we just try and do the best we can as a small 4-person team to try and change culture. We spend a lot of time trying to like improve processes and flows for people when they come in. But the culture doesn't change like that.
No, but I was there, I was obedient, I did not yell, I didn't get angry with anybody, I was very polite and everything, I did what they told me to do, and that, why come and say to me, no, you gotta leave, when I'm going along with what they're asking me to do.
Right.
You know?
I hear you, and I think that from what you've told me, that sounds like bad care.
Yeah.
I
And
can't
can-
speak to it because I wasn't there, and I hope that you would have put a complaint
I
in,
did.
so that. could
That's
be
what we don't know
followed
how to
up.
do. We were trying to figure out the exact workings of a complaint, because we might be able to do some of that
Well,
here.
I mean, numbers get results in healthcare.
Mm-hmm.
Like every time someone,
Who do we talk
I'll tell you. Every time someone doesn't get meds and ends up using and exposing a nurse, I put something called PSLS in, Patient Safety Learning System. The more we can document, hey, nurses are getting exposed,
Oh,
hey,
I
patients
see.
aren't getting meds, the more they can be like, hey, there's a problem. You know, just saying, hey, this happened, that happened, okay, well, where's the
And we
numbers?
want the
So we
paperwork.
need numbers. So the more complaints they get put in, the more they can say, hey, we
We
need
can
more
help with that.
people right at the front doors to support people and wait with people. We need to get NANDU in, we need to get peer organizations in to sit and wait with people like they do in Victoria, like they do at St. Paul's where I used to work
We
as
are
well.
hoping to do a peer leadership program, which
Still
will,
people.
to
Yeah.
implement that this
Yeah.
summer, hopefully, but that's a component of it is having, people with lived and living experience in substance use and placing them in leadership positions like
Yeah.
in collaboration with the hospital, so that way we
Yeah.
can get people to help us.
Yeah, I mean, our team will get the heads up every once in a while. So, hey, Keegan, can I talk about our experience when you came in? Do I have
Is it
consent?
important? Yeah.
So when you came in for your injury, can I share a little bit about that?
Yeah, of course.
Okay, so our team got the heads up that Keegan hurt his arm, right? And we heard that Keegan was coming in, and we want to make sure that Keegan is comfortable when he comes in, because you have pain. And we wanna make sure that Keegan's arm gets looked after so it doesn't get infected, and because we don't wanna see Keegan's arm get